All right, let's dive in. In this explainer, we're not just going to memorize a list of maternity medications. No, we're going to build a visual story, a mental map that follows the whole journey of childbirth. From the very first signs of labor to the final stages of postpartum care. We'll look at what happens, when it happens, and this is the most important part, why it happens. That way you can walk into any exam or real-life situation with total confidence. Let's get started. So picture this. You've got a patient, she's 30 weeks pregnant, and boom, contractions have started way too early. Your number one goal right now is to hit the pause button on labor. You have to buy that precious, critical time for the fetus to develop. And this is exactly where our journey begins, with the challenge of stopping an early arrival.
So here's our roadmap. We're going to follow the logical timeline of birth. First, we'll tackle managing preterm labor. Then we'll switch gears and look at inducing labor when it's needed. After that, we'll deal with the very real threat of postpartum hemorrhage, cover the baby's first essential meds, and we'll wrap up with some key post-delivery care for mom.
Okay, so back to our patient at 30 weeks. Labor has kicked off way ahead of schedule. Our first job is to stop this early arrival. And to do that, we have a specific class of drugs designed for this exact purpose. The medications we reach for are called tocolytics. Let's just break that word down for a second. Toco has to do with labor contractions, and lytic, well, that means to stop or break something down. So tocolytics have one clear mission: tell the uterus to chill out, relax, and stop those contractions, to halt a preterm birth. Simple as that. Now, our main player here is magnesium sulfate. This stuff is a true powerhouse because it does two totally different but equally critical jobs. As a tocolytic, it's a central nervous system depressant that relaxes all the smooth muscle in the body, and that includes the uterus. But it's also the go-to drug to prevent life-threatening seizures in patients who have preeclampsia. So it's kind of like a two-for-one solution for two really serious problems. Because mag sulfate is such a powerful depressant, safety is everything. This right here, this is your non-negotiable safety checklist before you even think about starting it. It's like the body's early warning system for toxicity. Are there respirations over 12? Yep. Good. Is that patellar reflex present? Check. And is there urine output more than 30 milliliters per hour? If you get a no on any of these, that is a huge red flag for toxicity. So what happens if your safety check fails and you think you have a toxicity situation? You need the antidote, and you need it now. And that antidote is calcium gluconate. For any test, and honestly, more importantly, for any real clinical setting, you have to know this. It needs to be right there, ready to go anytime a patient is on a mag sulfate drip. So while the tocolytics are doing their job buying us that valuable time, we're going to use that time wisely. We give a corticosteroid, something like betamethasone. Its whole job is to cross the placenta and basically put fetal lung development into hyperdrive. It boosts the production of surfactant. That's the stuff that keeps those tiny little air sacs in the lungs from collapsing on themselves. It's a simple shot that can make a world of difference for a preemie's ability to breathe. Okay, so we've successfully hit the pause button on labor. But what happens when we need to do the exact opposite? Let's totally shift gears and look at how we get labor started, or maybe just help it along when things have stalled out. Look, you can't just jump straight to strong contractions if the cervix isn't ready. It doesn't work that way. The very first step is what we call cervical ripening. And for that, we use prostaglandins. Think of these as the crew that prepares the gateway. Their job is to soften the cervix, make it more flexible, so it can start to thin out and open up. That's always step one. Once the cervix is ripe and ready to go, then we bring in the big gun, oxytocin. This is actually the body's natural hormone for contractions, but we use a synthetic version to really get the job done. It's a powerful uterine stimulant that amps up the force, the frequency, and the duration of contractions to move towards a successful birth. But here's the thing about oxytocin. It's so powerful that sometimes it can work a little too well, causing something called uterine hyperstimulation, which can really stress out the baby. If that happens, you have to act fast. This right here is your emergency plan. First thing, and I mean immediately, stop the infusion. Then, turn the patient on their side to get better blood flow, flood them with plain IV fluids and give them oxygen. And then you call the provider. Okay, the baby is born. Everyone's celebrating, but the danger is not over. Not yet. Our focus has to shift immediately to the critical aftermath and the single biggest threat to the mother in those first few hours: postpartum hemorrhage. I'm not exaggerating here. Postpartum hemorrhage is the #1 cause of maternal death around the world. See, after the placenta is delivered, the uterus, which is a giant muscle, has to clamp down hard to close off all those blood vessels. If it doesn't, a condition we call uterine atony, it can lead to a really catastrophic amount of blood loss fast. Now to fight this, we've got two main power players in our toolbox, and it is absolutely crucial you know the difference. Both methyl-organovine and carboprost cause those powerful uterine contractions we need, but the key for your exam and for safety is knowing when not to use them. Methyl-organovine is a vasoconstrictor, so it's an absolute no-go for a patient with hypertension, and carboprost can cause bronchial constriction, so you never ever give it to someone with asthma. I want this to stick in your head forever. Before you even think about reaching for the methyl-organovine, your first move is grabbing the blood pressure cuff. This quote says it all. The most important step isn't giving the drug, it's making sure the patient doesn't have high blood pressure, because this medication could make it dangerously worse. All right, mom is stable. Now let's shift our focus over to the newborn. In their first few hours of life, they get a couple of routine medications that give them some really crucial early protection. Let's talk about the why behind them. So pretty much every single newborn in the US gets a little ribbon of erythromycin ointment in their eyes. And this isn't just a good idea, it's actually required by law. And the reason why is to prevent a really nasty eye infection called ophthalmia neonatorum, which can be caused by bacteria like gonorrhea and chlamydia that the baby might have been exposed to in the birth canal. This one simple step literally prevents blindness. Next up is the vitamin K shot. To really get why this is so important, let's visualize the physiology. Newborns are born with a completely sterile gut. They don't have any bacteria in there yet. The problem is, we need gut bacteria to make vitamin K, and without vitamin K, the liver can't make the clotting factors that we need to stop bleeding. So this one little shot gives them all the vitamin K they need to prevent a potentially fatal bleeding disorder. Okay, we are in the home stretch now. The baby is safe, we've managed the immediate postpartum dangers for mom, but before she goes home, there are a couple more key things we do to make sure she stays healthy in the long run. This one is all about protecting future pregnancies. So, RhoGAM is given only under very specific conditions. If mom is Rh negative and she just delivered an Rh positive baby. See, during birth, some of the baby's blood can mix with mom's. This shot prevents her immune system from creating antibodies against that Rh positive blood, which could be really dangerous and attack a future Rh positive baby. Timing is absolutely critical here. You have to give it before her body has a chance to make those antibodies. Now, if we find out a new mom isn't immune to rubella, we'll offer her the vaccine before she goes home. And because it's a live virus vaccine, the single most important teaching point is this. She absolutely must avoid getting pregnant for at least 1 to 3 months. This is to make sure there's zero risk to a future developing fetus. And there you have it, a full visual journey from stopping labor to starting it and protecting both mom and baby every step of the way. We've seen that knowing what drug to give is really only half the battle. It's understanding the why, the physiology behind what you're doing that really sets you up for success. So as you keep studying, just think about which one of these whys paints the clearest picture in your head, because that's the one that's going to stick with you long after any exam is over.